So this is the first case. An 8-year-old boy presented to emergency department with recurrent epistaxis and spontaneous bruising. He is an adopted child to the parents or carer. The full blood count shows hemoglobin of 120, white cell count of 5, and platelet count of 102. This is the power 10 blood film, and we will go to power 50, but I need a volunteer from the lab side if they want to come in for the blood film. Is there any volunteer there?
I'll give it a try. So from this power, I don't think I can see any platelets, and I don't know whether I should comment on platelets in this power or not. It seems like there's no platelets. Some.
So this is power 10. Power 10 is just for general overview of the blood film to tell you whether there are white cells or not, there are clumps or not, or there is any worm if there is. This is an eosinophilia case. This is a general overview of the blood film. So now I will go to power 50, then you will find something. Ignore the moving object. So this is power 50, and you can see red cell morphology, the white cells and the plate. At this point, would you like to ask me any question?
I think I can see spherocytes here from this power. Spherocytes, is that right?
Spherocytes are very dark in color and small.
Okay.
So I see large forms of platelets. Large forms.
Large what?
Large forms of platelets. Platelets, large forms.
Okay. So you are seeing large platelets here.
Yes.
Is this related to the patient bleeding or not?
Yes, yes, maybe.
What do you mean, maybe?
Platelet function test we need, I think.
Okay. So that's why I asked you, would you like to ask me any question at this point among the investigations?
Yes, the blood film shows left shift also for the neutrophils. I see band forms, some activated lymphocytes, large platelets, mild thrombocytopenia. Otherwise, he has normocytic, normochromic RBCs.
Okay. So if I tell you this patient mean platelet volume is 15, would it help or not?
maybe pointed towards some congenital platelet disorders.
Okay, right. So we will talk about congenital platelet disorder. If you are sitting for FRCPath Part 2 exam, how would you report this blood film? Now you have seen the red cell morphology, platelet morphology, and white cell morphology.
يعني starting from history taking, or you ask about management, or just
No,
reporting the blood film and the...
reporting the blood film. So if you are sitting for FRCPath Part 2 exam, they will ask you to report the blood film or aspirate or refine. I think today we don't have many clinical hematologists to report the blood film. So you would say the blood film shows large size platelets or macrothrombocytes. The platelet counts are low in number. You discuss platelets first because the abnormality is in the platelet. So whichever line has the abnormality, you will mention that first. This blood film contains macrothrombocytopenia, no platelet plugs or clumps seen. White cell morphology is normal. Red cell morphology shows few echinocytes, which can be an EDTA. The blood film is consistent with macrothrombocytopenia. This patient needs further investigations to exclude congenital causes of macrothrombocytopenia. This patient is 7-year-old. He has recurrent bleeding and bruising, and he has macrothrombocytopenia. The next question would be, what are the different causes of macrothrombocytopenia?
One of them might be maybe ITP. Another cause is congenital platelet function disorders. I can't recall now any one of them actually. I think ITP is a differential, isn't it, as well?
Yes, ITP has large platelets, but they usually do not present with recurrent bleeds or dyslexis. Their platelet count is low, usually very low.
Yeah. So
But
when they ask about possible causes, shall we like mention the causes in view of the background history, or just according to the blood count?
background history, which is the likely cause, should be on the top, which is the
Yeah.
least likely cause, should be at the bottom of the list.
طيب سامعين يا جماعة السلام عليكم.
So you mentioned that congenital causes of macrothrombocytopenia and ITP. So I would keep the congenital causes on the top and ITP at the bottom of the list. Now, congenital causes are many. Do you remember any name?
طيب انتوا الحين مثلا احد وعددكم 25 عندكم غياب فما عارفه. المحاضرة اليوم هي عن الجنرال كونسيبت اوف لابوراتوري داتا. المحاضرة مهمة. CNS انا ما عايزة اشتغل اليوم لانه اصلا هي بالنسبة لي ممكن تسجل، ممكن نديها في اللاب، لكن الجنرال كونسيبت اوف داتا مهمة. ف رايكم ايش، عايزين CNS ولا نبدا باللابوراتوري داتا؟
لو سمحتي
حتى هي السلايدز بتاعتها كثيرة يعني ما هي بسيطة، فلو بالدوام بتكون شوية صعبة انكم تقعدوا اكثر من ساعة، يعني هي المحاضرة ساعة وشوية، فنفتكر افضل نديها.
Can someone ask her to mute the phone, please? Or if you are muted. Yeah. Thank you.
Okay, so with Scott, I'll dress.
Okay, so right. If they ask you what are the different causes of macrothrombocytopenia, So there are 4 congenital causes, and one is idiopathic, which is ITP. Congenital causes, you can make a mnemonic. I have made a mnemonic BMGX. B starts for Bernard-Soulier syndrome. M starts for MYH9 syndrome. G starts for gray platelet syndrome. And X starts for X-linked thrombocytopenia with dyserythropoiesis. So these are a few causes of macrothrombocytopenia. Then the next question they can ask you in the short cases will be, what further investigations are required to confirm diagnosis? So now you are at congenital thrombocytopenia part. What further investigation do you need to confirm diagnosis?
Maybe some genetic testing?
Maybe some genetic testing is not an answer.
Yeah.
You are sitting in FRCPath Part 2 exam. You need to answer accordingly. You have full blood count, look for mean platelet volume, whether it is high or not. Then we have discussed the differentials. According to the differential, you will go down the route to investigate the cause. We discussed that case previously in the last part 1 session. Hopefully you will remember something. If not, then full blood count you have already. Blood film is the second one. Platelet volume is the third category. Then you will send the patient for you will send a blood for platelet aggregometry, light transmission aggregometry, to find out what is the response to ristocytine and other agonists. And then you have flow cytometry, because the Bernard-Soulier syndrome have a defect in CD42. After that, you can say, I will go for genetic test, because these diseases are confirmed on genetic investigation. So what is the genetic mutation associated with Bernard-Soulier syndrome? GP9, GP1BB, or GP1BA. These are the genetic mutations that you can get in Bernard-Soulier syndrome. It can be a part 1 question as well. They will ask you what is the genetic mutation associated with that, or what is the inheritance, it is autosomal recessive or dominant, and where is the defect, in which glycoprotein you have a defect. Do you remember which glycoprotein is defected in Bernard-Soulier syndrome?
1B95.
Glycoprotein 1B95 is the defective. So if you are working in pediatric department, you will see many such cases of macrothrombocytopenia. You can see this platelet, it is bigger than the size of the RBC even. It's quite big. It is almost like an RBC. So macrothrombocytopenia usually comes in short case, or they come in the coagulation paper, where they will give you LTA, light transmission aggregometry graph, and a scenario, and they will ask you for the management of this patient. In my exam, Bernard-Soulier case was a Viva case. All right, so this was the first case. Now, the second case is a GP blood film about a 70-year-old patient who has routine blood tests. Let's see. All right. So anyone from the lab side, because the blood film first goes to the biomedical scientist or lab hematologist if they want to volunteer to comment on the blood. This is power 10 at the moment, and then I will go to power 50. Anyone from the lab side?
I can see a lot of lymphocytes, monomorphic like lymphocytes, and I can see one smear cell, 2 smear cells.
Okay.
The
You are
WBC count looks like increased, and there are atypical cells on the film, as well as a few neutrophils, and there are a reduced number of platelets, and RBC are mostly macrocytic.
clinical hematologist or lab scientist? Who was that? Who was speaking? Okay. All right. So this patient has a high white cell count, and as the candidate mentioned, there are many smear cells as well. For example, the uh, biomedical scientist or the lab staff think that this is lymphoma or acute leukemia, sorry. And this film has been referred to clinical hematology registrar to comment on that. Is there any clinical hematologist who want to report this blood film? What happened? There are 20 people in the session, and no one is replying. Anyone?
I can try Army, but I really apologize about the background noise I have.
No problem. I have also background noise here. It's okay. It's Sunday. Everyone is at home.
Yeah. So I in the blood film I will start first like by saying there is some red cell changes. I will start with this one, although like I know that the elephant is in the room. The red cell shows some. I can see some microcytes, some spherocytes, and platelet look morphologically unremarkable, and in the white cells, I would say there is a leukocytosis with a medium to large size cells. Some have a condensed chromatin and a high nucleocytoplasmic ratio. Some have a prominent nucleoli, and few of them have also some like deep cleft. And there are some smear cells as well. It's actually that some have actually like a rosette sort of morphology. So it's likely an acute type of leukemia, and I would suggest further investigation, bone marrow testing, and flow.
Patient is completely normal. He has no symptoms. And yes, some of these cells has prominent nucleoli. Like in this field, this is the only prominent nucleoli. The rest of the nuclear material is very blue and mature.
So some of these cells look like a CLL sort of morphology. Plus the smear cells that support that, but I'm not quite sure about because there are some like cells which are like a bit larger in size, and this prominent nucleolus make me a bit confused about the possibility of some malignant transformation or like
Prominent nucleoli will be there, because if you are suspecting a CLL, so CLL can have prolymphocytes, and prolymphocytes will have prominent nucleoli. But the nuclear material is very, very mature, very dark. In acute leukemia, the nuclear material is very open, orangish color. Yeah.
Yeah. And how can you describe this cell that you just passed through? It has some like a blibbing, and some of these have like a flowering sort of outline. Like that. Yeah.
Like this one.
That one. Yeah.
So what do you think? This is acute leukemia. This is CLL. This is ALL, or this is ATLL.
I think we have some dimorphic picture here with these like more mature, smaller and more condensed chromatin cells, and others are a bit more like medium to large size. Oh, this one is really. Could that be Sézary? I don't know. Oh, like.
No. Sézary are not like this.
There are increased number of atypical lymphocytes with condensed nuclear chromatin, but some of them are showing clefts, or you would say twisting of the nucleus. Looks like prolymphos, and I would go with a prolymphocytic leukemia.
Prolymphocytic leukemia. Which prolymphocytic leukemia? B or T?
B cell PLL.
BPLL. There is no BPLL anymore after WHO 2022. There is only TPL.
Right, okay.
So I brought this blood film because in the previous morphology courses, our sessions, when I brought this blood film, people directly jump to ATLL. ATLL has a clover leaf shaped nucleus. Okay, so a flower. Some people say cauliflower, clover flower type of nucleus. Like that. But the main purpose of this blood film is that this is not ATLL. All to these nuclear material is in the form of this flower-shaped nuclei. But you never say this is ATLL on morphology or this is TPLL or morphology, etc. There are only few cells which are like this, but the rest of the cells, they are quite mature. Their nuclear material is very mature. You only say likely lymphoproliferative disorder. We need flow cytometry for this patient to confirm the diagnosis. Because this patient has almost white cell count is 70. A lot of them are mature. Only one or few of them are having flower-like type of cells. Patient is completely normal. The patient with ATLL would have constipation or polyuria, or they have some sort of symptom presenting. But this patient is completely normal. So you never make a diagnosis on morphology. Always say likely or possibly. Then you are saved in the exam. Like I would report this film like that. This blood film contains leukocytosis with normal platelets and RBC morphology. The white cell or the leukocytes, um, they are small in size, small to medium in size, with condensed nuclear material, some of which uh, contain a prominent nucleoli. There are a few cells which have nuclear material in the form of cloverleaf shape. This represents a likely lymphoproliferative disorder. We need a flow cytometry to confirm our diagnosis. You have suggested flow cytometry for this patient. So now, if I tell you that this patient flow cytometry was CD5 positive and CD10 negative, 23 positive, 43 positive, 25 negative, what do you think I'm heading toward diagnosis?
It's going towards
CLS.
Sorry?
CLL.
CLL. Yeah,
CLL.
it is a CLL. CLL is CD5 positive, 23 positive, 43 positive. I mentioned 25 negative because ATLL is 25 negative. All right. The main point here was that do not make diagnosis on just on the blood film. If you see cell like this, which is cloverleaf, and you say that this is ATLL. No, look at the scenario as well, and look at and suggest flow cytometry. If they have given you flow cytometry, it will be very easy to confirm your diagnosis and to make your diagnosis. If not, then you have to suggest. There are many clover leaf like cells, but this is not ATLL, this is CLL, chronic lymphocytic leukemia.
Sir, there is a variant CLL in which the pro-lymphocytes are more than 10% but less than 50%. I think I'm correct with the figures. Could it be that?
It is. It has a very difficult name. Um, Clinical lymphoma leukemia with prominent nuclei, but they should have 50% of prolymphocyte. The previously called BPLL has been removed now from WHO 2022. If you open WHO 2022 classification, there is no BPLL.
All right,
There
sir.
is a
Yes.
there is a new category called splenic lymphoma leukemia with prominent nuclei, which contain two categories. One is BPLL and another is hairy cell leukemia variant. Both of them has been mixed together and now it is called splenic lymphoma leukemia with prominent nuclei. This is another case. This is a 80-year-old patient who presented to you with worsening back pain. He has a previous diagnosis of multiple myeloma and he has been started on non-transplant eligible category chemotherapy, VCD. This is the blood film of the same patient who has come back to you with worsening back pain. The blood test shows uh, AKI stage 2 hypercalcemia and hemoglobin is 90.
Which
So
same patient did the CLL?
no. This is a new patient who is a 70-year-old patient with the previous diagnosis of multiple myeloma on VCD chemotherapy, presented to you with worsening back pain. The blood test shows AKI stage 2, hemoglobin 90, hypercalcemia, and this is the blood test. Any volunteer?
The RBCs and platelets seem to be normal with slight ruler formation in the RBCs, and I can appreciate plasmacytoid lymphocyte in the blood film.
I will make it power 50 for you to make it more clear for you. What is this?
Plasmacytoid lymphocytes in the blood film.
Why are you calling it plasmacytoid?
They do not have the typical plasma cell morphology.
What is the typical plasma cell morphology?
They're medium-sized cell with eccentric nucleus, clock-shaped nucleus, and cytoplasm, which should be basophilic.
So do you think this is plasma cell?
Not a true plasma cell.
Is this eccentric? There is a halo. There is a halo here.
Yes, slightly eccentric. Yes.
Okay. There's a ruler formation as well. Affected counts are okay. This is also a plasma cell with halo formation. Some more. Right. So now we had
They look
central.
like more than 5% plasma cells.
Hmm?
They look like. Do they look like more than 5% plasma cells on the blood film?
Yes, they are more than 5%. In multiple myeloma, you do not see this much plasma cells in the blood film.
That'd be like plasma cell leukemia.
Plasma cell leukemia. Why are you saying plasma cell leukemia? As I have already told you that this patient has previous diagnosis of multiple myeloma. Yes, in general, according to IMWG definition of plasma cell leukemia, if the plasma cells are more than 5% in the peripheral blood, you call it as plasma cell leukemia. But this patient has already a diagnosis of uh, multiple myeloma, and a flow cytometry shows he has CD56 positive with other myeloma flow cytometry. So the main point behind this blood film is that you can get a question in the exam which will tell you that the flow cytometry is showing CD56 positive. But when you open the blood film has a lot of plasma cells. You would think that whether the initial diagnosis was wrong or now the patient has developed any plasma cell leukemia which cannot be possible. This is called spillover myeloma. When the myeloma becomes refractory or relapse and the bone marrow is overwhelmed, although your plasma cells have CD56 positive, which is a ligand protein, do not allow anything to go out of the bone marrow because they are overwhelmed. So you will see plasma cells appearing in the blood film of multiple myeloma patient. This is called spillover myeloma. We had a question like that in the exam. Hopefully it will not come for you. So always when you see a blood film like that, which has more than 5% of plasma cell in a blood film, look at the flow cytometry if it is given. If it is given and it shows that CD56 is positive, then it is likely a spillover multiple myeloma. If the CD56 is negative, which is a case in plasma cell leukemia, then it is a plasma cell leukemia. hopefully now you would be able to differentiate what is spillover multiple myeloma and what is plasma cell leukemia. And
Sir, if we are
spillover,
not provided with the flow cytometry, how will we report this blood film only on the morphology?
okay. So on safe side, to report this blood film, if you have no flow cytometry and no history, then you say this blood film contains leukocytosis with multiple rouleau formation and normal platelet count. The blood film has multiple plasma cells, which are likely more than 5%, representing plasma cell dyscrasia, i.e., plasma cell leukemia. But we need to confirm this diagnosis on flow cytometry. In the bracket, you can write if it is CD56 negative, it is plasma cell leukemia. If it is CD56 positive, it is multiple myeloma. But this particular patient has multiple myeloma history already. I would say this blood film contains leukocytosis with red cell rouleau formation and normal platelet count. The uh, the plasma cells has a typical morphology in the form of eccentric nucleus and halo formation around the nuclear material. This still represent plasma cell dyscrasia, and the history of previous multiple myeloma represents that this patient has likely developed a spillover multiple myeloma. When you say spillover multiple myeloma, it means the patient has either become refractory to the current treatment or the patient has relapsed after going into remission. So be ready for such cases in the exam as well. If I haven't told you that this patient has multiple myeloma previously, then this is plasma cell leukemia. And if you do flow cytometry, it will be 56 negative, CD56 negative. If I told you that this patient has previous history of multiple myeloma or CD56 is positive, then it is likely spill over multiple myeloma. Because multiple myeloma has CD56 positive, plasma cell leukemia has CD56 negative. And CD56 is a ligand protein. It does not allow plasma cells to go outside the bone marrow. Hopefully, it will be clear now.
Yes, sir.
But such
Very clear.
cases do appear in FRCPath exam, so be ready for such cases as well. And if you are working in tertiary center and you have myeloma patient, then you must see a spill over multiple myeloma. Or ask your lab, they would have such blood film as well. Now, the fourth case is a 60-year-old patient with eczema, profound eczema almost covering the whole of the body. Right. Is there any volunteer to go through this question?
Sir, please zoom a little.
Okay. I will go to power 50. Let's see few cells and then you can comment on that. Any idea about the nature of this cell?
Sir, they look like lymphocytes.
They are lymphocytes, but we want to see the characteristic morphology of these cells. Do you have any differentials in your mind?
Sir, the first one that comes to my mind, Sézary cells.
What is the morphology of Sézary cell?
Cribrated nucleus. These cells also have something like that.
Do you think this is a Sézary cell?
Yes, sir, I haven't seen before, but what I read about their morphology, so I think yes, this is.
Mhm.
Can you focus more, Dr. Amr? Yes.
Yes, I'm searching for a typical cell that will.
It's the cell has scanty cytoplasmic projections. Scanty cytoplasm, but there are projections also. Am I right?
They are very, very scanty, very, very few. So I'm searching for a typical Sézary cell to show it to you so that you cannot forget in the exam.
So for me, this looks like mature cells, like CLL cells, generally.
They are.
Is it in your differential, like when you have a first look to the blood film? Do you think about probably just mature, like B lymphocytes for CLL?
But they are bigger than the CLL cell.
Okay.
CLL cells are a bit small, and these cells are a bit bigger. The nuclear content is mature in both, but the Sézary has typical cerebriform appearance or what is this? A dry fruit called when you open it and it has a cerebriform appearance. Some type of nut. I know the name in my language, but I do not remember it in English.
Sir, please tell in your language.
My language is Pashto, you do not understand.
Sir, I am also Pathan. That's why I was asking. Maybe I would know in English too.
Maybe.
Do we need to give differentials while looking morphology only?
If they ask you in a separate question, what are the differentials, then you have to give differentials. Otherwise, not. So I think this a bit resembles to the cerebriform appearance. If I make it more big, this compartment.
Is it cerebriform? Cerebriform? Is it? Do you mean like the brain?
Like the brain, cerebriform, like the brain. And this patient has a history as well of eczema. So if there is eczema history and you have cells like this, it most likely goes with the Sézary syndrome. Like this one.
But not all of them looks like cerebriform nucleus. So
Yeah, but
some of them are like CLL cells, or do you think all of them are Sézary cells?
Not
Or
all
not
of them
all
are
of them like obviously Sézary cells.
not all of them are Sézary cells because not all of them has cerebriform pattern.
Okay, so there are some mature lymphocytes then.
Yes.
Sorry, can I comment? It might be like hyperchromatic type of cells. It's not just mature, hyperchromatic.
Hyperchromatic. What do you mean by hyperchromatic?
Yeah, usually the T cells, usually the maturation of the cytoplasm like hyperchromatic, so it might be pointing a clue like it's likely one of the T cells neoplasm.
Never heard about hyperchromatic terminology. Sorry about that.
No, that's okay.
I think maybe that is more used in histology.
Now these three cells, if I make them more clear.
So what would be the percentage of these cells in the periphery for diagnosis?
No, there is no need of any percentage of the cells. It is only the morphology of this nuclear material, which is mature and has ups and downs in the nucleus. Like someone put water in the flour and then put a hand in the flour before making the bread. It has appearance like that. So it has quite a lot of Sézary cells, but the typical appearance in which it has a central line in between and has cerebriform appearance on both sides, they are not here. But I think
Can I ask a question? Is it easy to differentiate, or you need to be like suspicious?
It is easy
having
to
had
differentiate.
in the history, for example,
easy.
or you need to look specifically to see Sézary cells, or it should be obvious? Because what I saw now, you have to be on a high power to judge that this is Sézary rather than just mature lymphocytes. Am I right?
if you have given a history of eczema, so eczema either goes with eosinophilia, so you will be thinking that maybe this is there is eosinophilia, idiopathic eosinophilia, or associated with any myeloid disorder. Another, you would think maybe this is some type of worm. So you will see the slide on power 4 first. And the third cause of eczema in the hematology, the widespread eczema in hematology is Sézary syndrome. So you would prepare your mind to see these type of cells. Now this cells which is in front of you, it has a central line in between and folds on the others on each side. It resembles more to a cerebrum than to cells of CLL. In CLL, you do not expect to have eczema or erythroderma. And these cells are a bit larger than the cells of CLL. In CLL cells, they are almost the same size as that of the RBC. The CLL cells are very small. And CLL cells has smear cells as well, plus prolymphocyte. This one has no smear cells and no prolymphocyte. All of the cells are mature, and half of the cells has morphology like that. I think this cell, which is in front of you, is more clear towards cerebriform nucleus. Now this one as well has lines inside. So their nuclear material is not uniform. There are a lot of indentation in the form of cerebrum, and they have a central line as well in between. And the history of the patient, they would guide you that these are Sézary cells and a diagnosis of Sézary syndrome. If you are working in NHS, your laboratory must have Sézary syndrome collection. They should help you with that, but do see them before the exam because they always come in the exam. All right.
So you will describe this blood film findings as a medium to large sized cells with a cerebriform
Appearance.
nuclear.
Cerebriform nuclear appearance,
Yeah.
most likely consistent with a lymphoma. We need flow cytometry to confirm this diagnosis. Sézary syndrome flow cytometry is usually exclusion of other T-cell lymphoma because there are no typical markers to uh, suggest that this is T-cell lymphoma. Like for ATLL, you have specific flow. For LGL, TLGL, you have specific flow. For TPLL, you have specific flow. For PTCL, you have specific flow. But for Sézary syndrome, you have symptoms and exclusion of other T-cell lymphoma. Right, so this is the last case. This is
Thank
the aspirate.
Thank you so much.
This is the aspirate of 30-year-old female who presented to ED with epistaxis and bruising. This is power 4, just to see if there is any particle in this aspirate or not. It looks like there is no particle in this aspirate. So you will go to power 10. And you can see the cellularity. Now this is power 50. What type of cells do you see on this aspirate?
Like the promyelocytes.
And what is promyelocyte? Just for the audience knowledge.
Yeah, it is one of the cells of granulocytic lineage, immature form white cells.
Mm-hmm.
Usually it's big cells and could be hypergranular.
Okay.
malignant promyelocyte, right?
Yeah.
These are malignant promyelocytes,
Mm-hmm.
medium to large in size, with adequate cytoplasm, a convoluted nucleus, may have nucleoli, and the cytoplasm, when it's granular type, it has granules. And in both the granular or agranular type, we can appreciate R rods.
Have you seen overall? If you
I
haven't
was
seen
about to
overall,
ask, actually, I haven't seen an hour road.
if you haven't seen overall here, do not mention it in your answer.
Yeah. So far, it's mainly hypergranularity. I can't appreciate all roads so far.
So this is granular, and this cell is bilobe. This is one lobe, and this is another lobe. There's a lot of granular cell and the blasts and promyelocytes. I think it is easy to diagnose APML on aspirate than on blood film. But sometimes the APML variant is pancytopenic, and you can miss the APML on blood film. So yes, this patient has epistaxis and bruising. And you can see the aspirate is full of myeloid lineage, large promyelocytes. They are hypergranular. Some of them are bilobed. And
there are few with nuclei as well.
yeah. How would you treat this patient?
Yeah,
With
so
Etra and arsenic or with Etra and idarubicin?
What was the patient age and comorbidities?
Patient is 30 years age and has no comorbidity.
yeah, so and the white cell count.
Excellent. You have asked the question that I was hiding. The white cell count is 20.
Sorry, how much is the count? I didn't get that.
20.
Yeah, so Atra and idarubicin.
Yeah.
Yes, Etra and idarubicin.
Yeah. And obviously to treat the underlying, if there was any coagulopathy, the supportive treatment.
Yes, this patient has epispexis and bruising. So the patient may be in BOIC.
Yeah.
Usually these patients has very low fibrinogen count, and you need to check the fibrinogen level twice daily to make sure their fibrinogen is above 1 in some trusts, about 1.5 in other trusts.
Yeah.
Yeah. So different trusts have different range. Our trust has 1.5 range, and
yeah, also we say 1.5 in our trust. Yeah.
yeah. And if this is a patient in your part 1 exam or in part 2 exam, you need to start treatment as soon as possible. Do not worry for fertility preservation because you don't have time to wait for fertility clinic appointment. Just mention, I would have considered fertility preservation, but this is a hematological emergency. I need to start treatment as soon as possible.
Yeah.
So I will prioritize my patient and I will start treatment. There is another kidney shaped or bilobed nucleus.
Yeah.
Right, so this was the last case. Do you have any question?
Sorry, just a question for the case number 4. What is, you mentioned usually is a differential for if there is a history of eczema or skin condition. Yeah, what is the differential again, apart from the Sézary?
So if you have a scenario like which says that there is eczema in the patient.
Yeah.
So mild eczema can be in any T-cell lymphoma and in Hodgkin disease. But a severe eczema, which comes as a erythroderma, the whole body is covered with the eczema, and they have given you a peripheral blood film. It means either this is a case of eosinophilia, or this is a case of T-cell lymphoma, Sézary cell lymphoma.
Yeah.
Or macrosis fungoides. And if it was a Hodgkin disease, they would give you a trephine, because you have to see the Reed-Sternberg cell in the trephine. In the peripheral blood, you cannot see Reed-Sternberg cell, or in the aspirate, very rare.
Okay.
So that's why I say the exam is a little need skills, and all of you have knowledge about Hodgkin, Sézary, everything. But to save your time in the exam in the 9 minutes, if they say this patient has a full blood count shows eosinophil count of 4 since a year, and patient has no travel history, nothing. This may be idiopathic eosinophilia, or if you see the blood film, it can be associated with acute myeloid leukemia.
Yeah.
If this patient has pruritus all over the body, refractory pruritus, not responding to any medication, so likely a T-cell lymphoma, Sézary syndrome. If this is a young female, 24-year-old female with lymph nodes as well, and the blood film and the full blood count is eosinophilia, and the symptom is pruritus, then you would think that it can be a Hodgkin disease. So they would have given you a trifine for you for that. So the stem of the question and the patient's symptoms and age, relate them, then you will get the answer. For example, if they give you an exam that this is a 19-year-old male patient or female patient with cervical lymphadenopathy, so most likely it is an infectious mononucleosis. You will see reactive blood film, reactive lymphocytes. If they say that this is a 2-year-old boy with white cell count of 50, so most likely they are talking about acute lymphoblastic leukemia, either B cell or T cell. B cell has high count, T cell has less count. So again, if they say that this patient is unwell, he had traveled to Jamaica, or this patient has polyuria, or this patient has constipation because of hypercalcemia. So they are talking about ATLL.
ATLL, yeah.
ATLL has high calcium. Or if they say this patient has history of rheumatoid arthritis, and now he is persistently neutropenic, and you see the blood film and you see large lymphocytes, the lymphocyte would have a structure of a large granular lymphocyte. So it is either TLGL or NK. And if they say this patient has high count and with ascites or with pleural effusion, you will see lymphocytosis in the blood film just like CLL. But if you observe the cells, they would have blebs. So it would be a TPLL.
Yeah.
TPLL comes with effusions, either pleural effusion or ascites. So the scenario help you a lot.
Yeah, scenario, and sometimes might be a flow cytometry as well in the stem.
If you are lucky, you would get the flow. In my exam, they had given you only one flow for CMML case. In the other question, they asked us what is the expected flow cytometry.
Yeah.
So if you are lucky, you will, and you get the flow cytometry, you can make a diagnosis without seeing the blood.
Combination of things. Yeah, you're right.
Yeah.
Thank you.
Flow cytometry makes the diagnosis very easy. You are then confident what are you seeing in the blood. Okay, so this was our 14th session. We will continue slowly and slowly our sessions, and subscribe the channel, Hematomorph, and if you want to join the group. I'm not active over there, but people do discuss morphological cases. You can scan this and join the group. And thank you. Have a nice sunny Sunday, and see you next week.
Thank you very much.
Okay.
Thank
Take
you.
care.
Thank you.
Thank you. جزاك الله خير.